triangular area until you get to the clavicular head. So we can take the next slide. So again, keep contouring. You can see a little bit of thyroid in the upper still, and so trying to avoid that. And then still on the lower slide, that triangular, yep. And then, yeah, you stop contouring when you get to the clavicular head. Can you go back to the previous slide? So the level 3 axilla, it ends when the vessels, the axillary vessels, cross the pec minor muscle. So you can see that big fat pec major muscle on top, and then that little tiny pec minor muscle, and then the thicker area is actually the axillary vein and artery. And so when those start to cross the pec minor muscle, that's when the axillary level 3, that's the lower border. But you can see the slice of the level 3 lymph nodes. The landmark for that, again, the pec minor muscle, and for level 3, that's the medial aspect of the pec minor. And then it's underneath the pec major. And then it covers that triangular area, as you can see how it's outlined there. And then the next, they put the matched line, and so you would stop contouring axillary level 3 at the matched line, and then the breast and chest wall contours will come into play. And again, in this case, they felt that the chest wall was at risk in addition to the breast, and so instead of putting the breast, just the breast contour above the pec muscles, they included the pec muscles in this contour. And then you can see that they started contouring the internal mammary nodes also. So you can go to the next slide. And then because the breast is intact, you want to contour the seroma, and there's clips here, so you can see where the clips outline the seroma, because the breast tissue is very, very dense in this patient, and sometimes it is hard to identify exactly where the seroma ends and the breast tissue, is. So the clips are helpful if your surgeon does that. You can see on the surface there's the little tiny white. That's the wire, and that's the wire that was placed over the lumpectomy incision. And again, the contours of the breast, mid-axillary line, you don't want to contour the latissimus dorsi muscle, and then the medial border is up near the sternum. Next slide. So you just keep contouring, the breast, chest wall, seroma cavity, internal mammary nodes on every slice. Next slide. Next slide. Okay, and then you can see those little tiny white dots on the surface. That's the wire from the inframammary fold that you place around. It's kind of like a half moon shape that you just put around the inframammary fold. Again, I don't do that anymore. I used to do it, but I didn't find it as helpful, but I think sometimes it can be helpful for the lower border. Next slide. So, and actually, I think the wires can be helpful in the inframammary fold for the couple last slices because it is hard to see where the breast tissue is there. And so you can actually use that as a good landmark for the medial and lateral borders. Next slide. And again, you know, look at it in the coronal and sagittal views also, just to make sure that what you contoured makes sense and that you didn't miss anything. Next slide. Okay. You can keep going through these slides pretty quickly. You can go to the next one. Yeah. So sagittal views. Yeah. So again, the difference in this one is you're contouring intact breast plus the chest wall, which includes the pec muscles and the ribs, and we're just covering supraclav and axillary level 3 because it's less than 50% involvement of the axilla. Okay, next slide.
This is the last slide.
Oh, this last, okay. So I don't know if anybody has any questions. I think that the contouring is really helpful. I think you guys have these slides, and so
Yeah.
you know the charts are a little confusing, but when you actually look at the contours, I think it makes a lot more sense.
Okay. All right. Question time. Right. Are we set to ask questions?
Yeah, questions.
Okay. All right. Questions.
Good afternoon, all.
Yeah. Good afternoon.
Yeah, I'm Abba calling from South Africa.
Hello. Just wait a minute.
Dr. Lisa, thank you very much for the presentation. I just want to have your opinion in relation to involvement of the lymph node in a situation whereby, particularly in the case number 3 that you presented, with lymph node 4 out of 18, which is less than 50%. If there is an extracapsular extension, and maybe let's say you have a pathologist who indicated clearly that level 1 is involved with extracapsular extension, will you still go along with supraclav electrode, or it will change? That is my first question. And the second question is, what happens to the breast when there is involvement of the skin?
Okay, so so it's a little hard to hear. I think the question was if there was extracapsular extension of the lymph nodes, and if that, so for like case 3, then definitely, yeah, I think you need to cover all 3 levels. You'd have to cover supraclav and axillary levels 1, 2, and 3. It's a great question. And sometimes what I do, I mean, if you know where that extracapsular extension was, you know, try to boost that area a little bit. And then I didn't catch the second question.
The second question is about a patient with a skin involvement. I'm speaking about a boost to the breast. So are you considering boost when there is an involvement of the skin or either a closed margin? Will you consider a boost or not?
So I heard if there's skin involvement.
Yes.
Sorry, I didn't hear the whole question. I just heard if there's skin involvement.
Yeah. Yeah, that's the question. If there's a skin involvement. Hello?
Yes.
Yeah. If there's skin involvement, would I do something different, I guess is the question?
Yes, yes.
Okay. So I guess it depends. So if you have, say, an inflammatory breast cancer, then I probably would cover all levels of lymph nodes. And then the question also, I mean, we use bolus on the chest wall. So, you know, if there was skin involvement up front, I mean, you would still, after the mastectomy, you'd still definitely want to put bolus on the chest wall for all of these cases. I don't know if I answered your question, but I would probably, like for an inflammatory case, I would definitely cover all 3 levels of lymph nodes, even if there was less than 50% involvement. They're just so aggressive. I don't know if skin involvement per se would be, you know, an indication to cover all 3 levels of lymph nodes. I still think if, you know, if they had skin involvement up front and they had a mastectomy and that was all closed up, and they only had, say, 1 or 2 lymph nodes involved, then, you know, you probably don't have to treat the whole axilla. It's hard. A lot of these are just judgment calls and, you know, what you think the areas at risk are going to be. And I hope that answers your question.
Thank you. But actually, what I am trying to ask is that if there is a skin involvement, may you consider giving a boost to the chest wall or not? That was my question, actually, not about the lymph node. Regarding the lymph node question, you have addressed that one. But if there is skin involvement, may you give a boost or only a bolus to this chest wall is sufficient?
Yeah, I still can't hear you very well. Can you repeat that, Credit? Did
Yeah.
you get that?
Yes, I did. He said, if there is a skin involvement, will you consider a boost or just
a boost.
Yes, a boost, or you just do it as you've done the chest wall?
So I think, yes, I would definitely consider it a boost. Yeah. So so I think that the question is, do you do a mastectomy scar boost? And that is one indication of a mastectomy scar boost. If you had skin involvement up front, if you had positive margins, that's also an indication for a mastectomy scar boost. I don't think there's anything wrong with boosting everybody. I mean, some people do that, but that's definitely an indication.
Okay. Nice.
Thank you so much.
Thank you very
I
much.
hope that helps.
Yeah. Okay.
Yeah, so we do bolus on the chest wall, and we used to do a 0.5 centimeter bolus every day, but then it ended up that everybody was moistly desquamating, and so now I think most of us do a 0.5 centimeter every other day when we're doing the tangents. When we do the chest wall boost, I do a 0.5 centimeter every day when we're boosting the chest wall scar. So I do it every day.
Oh, good evening.
I was just going to say, we're going to, we'll have another session where we'll go through the dosimetry and putting on tangents and superclad fields and how to match them and everything, and the bolus. So we'll probably do that, sometime soon.
Okay.
Good evening, Linda. Hello, good
Any
evening.
other questions? Or?
Yeah, good evening.
Good evening.
Oh, sorry. We have a question from Dr. Usman, right?
Good evening.
Yeah, good
Yes,
evening.
yes. Good evening. How are you, Linda?
Yes,
Good
yes.
evening.
Yeah, good evening.
Okay, good evening, Dr. Usman. We can hear you.
Good evening, Linda.
Could you,
Yeah, good evening, Linda. Can you hear me?
Yes. Hello, Dr. Linda.
Hello, can you hear me now? Yes. So my question is, if you have an axillary dissection and the surgeon or the pathologist reported that you have like less than 10 lymph nodes, is it still valid to use the rule of if you have less than 50, you treat?
That's right.
oh, yeah. So the rule is 50%.
Still,
So, I mean, if you, so, you know, it's a little judgment. So if you only have, you know, nowadays we're doing just sentinel nodes for a lot of patients. And then
okay.
if they have 1 or 2 lymph nodes positive, then they don't do a full axillary dissection. So a lot of patients are not getting full axillary dissections anymore. So in those cases, that's, I usually cover the whole axilla. You know, if they haven't had a full axillary dissection and they have a positive, then I think that you're obligated to cover levels 1, 2, and 3 with radiation. The question is, do you cover the supraclavicular area? I think most people
I want
would.
a network at the best. Sokoto.
Sorry. I think we can hear you. If the network is quite bad, you can just type the question. I think she can read it and answer it straight up.
On the chat. But I was going to say the rule, this 50% rule, is if you have a full axillary dissection, and if more than 50% are involved, then usually you'll cover all levels of the axilla. But if less than 50% are involved, then it's just level 3.
No.
But again, you know, it's not a hard and fast rule. It's a judgment call. And I think it's, you know, how much do you think those areas are at risk? So.
Thank you.
Okay. Thank you.
Thank you very much. Caller 18 had a question, right? I don't know who caller 18 is. Okay. I think she's left. All right. Any more questions, sirs?
Okay.
Yeah.
Yes, good evening.
Okay. You're back. Good evening.
Yes, thank you for this lecture. But I would like to ask that since the adipose tissue of the breast actually extends to the pectoral minor of the breast, so how do we really contour the total volume of the adipose tissue of the breast? I don't know if you understand my question.
Yeah.
Hello?
Yeah, I'm just really having a hard time hearing. Yeah. I heard. Did you get that credit?
Yes, I got it. So she's asking that the adipose tissues extend to the pectoralis minor of the breast. How do you then contour the adipose tissue of the breast? I don't fully understand it.
Yeah. The adipose. I mean the fat. I don't.
Hello, caller B. Is it possible?
Yeah, I'm not.
Okay. Is it possible to type your question? I think we're having problems with the connectivity, but you can type your question. I'm sure the text message works well with connectivity.
Yeah.
So, but that's what she asked. I don't fully understand it.
Okay. Well, I do see a question here. It says, what variations can be made for planning and contouring patients with bilateral breast cancer status post mastectomy? So I think I would still contour everything the same. You would have to contour both sides, but then you have to make sure that you're not overlapping. And it can get kind of tricky because if your mastectomy incisions are going over midline, then, I think that some of these can get quite complicated, but I think you have to match midline for these patients and make sure you're not overlapping. And that's actually a good situation that we'll try to cover. We'll try to cover that next time because I think bilateral breast cancer can get a little tricky when you're trying to match fields.
Right. Oh. Thank you very much, Dr. Linda.
Yeah.
Okay. Any more questions?
Anything else?
All right.
Yes. If you have bilateral breast cancer, you can do it together.
Okay.
No, we treat them at the same time. We treat both breasts at the same time. Or mastectomies, or whatever you're treating, you can treat them both at the same time.
Okay. All right. Thank you very much. So the question she actually asked, which has been forwarded by text message, is the breast contain adipose tissues and glandular tissues, and other parts of the chest area also contain adipose tissues and glandular tissues and fat tissues. So how do you totally segment the fat tissues of the breast? Oh, so how do you segment the fat tissues of the breast from that of the chest area completely? I don't think you have to do that. I'm not too sure.
I guess I'm not understanding.
Yeah, I'm not too sure you have to segment the fat tissues or the adipose fat tissues. That's what I think, though.
Yeah, I don't understand the question.
Yeah, I'm not. Yeah, that's that. I'm not too sure you have to segment them. That's okay. All right. Any more question? And in the absence of none, we'll just close the class for today. Thank you very much, Dr. Linda Grossham, for.
Oh, you're welcome. Thank you.
Thanks everyone who was able to participate in today's class, and we'll let you know about the next class, about the dosimetric. If we're going to have a dosimetric class, we'll let you know about that. And I'm just getting another question from here. Okay, this is to African oncologists. Do you have bolus? For the people in the class here, do you have bolus? Do you use bolus?
Yes, we do.
Okay.
Yes, we do.
How is a bolus actually different from a boost? I'm not. How is bolus actually different from boost?
The question?
Yes.
Well, a bolus is actually a tissue equivalent material. Hello?
Yes, we can hear you.
Tissue equivalent materials that you normally place, like if you want to treat your breast to break up the dust. to actually the surface. Like if you, an example, if you have a scar,
Okay.
usually boost if you are going to.
Okay.
That's right.
Yeah.
Yeah. So for mastectomy patients, you want to get a good skin dose because the biggest risk of recurrence is along the skin or the scar. For lumpectomy patients, the biggest risk of recurrence is in the lumpectomy. So you don't need to get a big skin dose and typically don't really need to use bolus on those patients. But mastectomy patients definitely need to get a skin dose. And so you need to use the bolus in order to get a good skin dose. And like I said, we used to do it every day, but then the skin dose would get so much that people were breaking down towards the end. So typically we do it every other day. But for the boost, if we do a mastectomy scar boost, then we do it every day. And typically we use a 0.5 centimeter of bolus when we're using the bolus for the chest wall.
Okay. Thank you very much. All right, so we'll organize a follow-up class with Dr. Linda, and I think that will focus on the dosimetry. But however, for those of us who have questions, whose questions could not be answered, you can just follow up with me and I'll link you up with Dr. Linda to follow through. I know caller 18's question was not so clarified. So if you're not satisfied, we can maybe we can have an email link with Linda, Dr. Linda, and she may follow up with that. So with that, I think we've come to the end of the class. Thank you very much, Dr. Linda.
There's one more. Yeah, there's one more question. So is the bolus on just the scar or the entire chest wall? So we do the bolus on the entire chest wall when they're undergoing, when they have the tangents. And then when we have done just scar, but the whole chest wall is at risk. So we do the whole chest wall. And then when they are having the boost, the field is small. It's just 2 centimeters around the scar. And so you can use a larger bolus because the field will make it smaller. So we use it on the entire chest wall.
All right.
Yeah, thank you.
Okay.
Okay, well, thanks, everybody.
Yeah, thanks very much, Dr. Linda. Thanks.
Okay, we'll talk to you soon.
Yeah.
Bye.